I'm back in plenary session, virtual edition. I'm joined by Gil Welch. Dr. Gil Welch should need no introduction. He is a spectacular professor. He is somebody who I've admired for many, many years, my whole career, actually, since I started medical school in 2005. Dr. Welch took a topic, I think, that was really hard to talk about, which is that in our pursuit of cancer screening, is it possible that we're doing some harm to people? And he took that topic, which I think was 100% taboo maybe 20, 30 years ago, and very tough to talk about, and turned it into something that is something we can talk about all the time and have a more reasoned discussion about, at least some of us. And he did so through, I think, the power of research and publishing dozens of really high-impact papers. Dr. Welch, it's a pleasure to have you back on the show.
It's great to be with you. Sorry I'm not there in person.
Oh, that would be, obviously in person is better. We were just talking about it before we got started. And I remember when you came and gave a lecture at OHSU, we invited you out to give a lecture.
That was a lot of fun.
That was a lot of fun. I had a student come to me afterwards. And, one, I have to tell you, ever since I saw your lecture, it really made me rethink my lectures, because I felt like, your lecture was terrific. The student came to me after the lecture, and I said, I told him to come to Gil Welch's lecture. It's going to be a good lecture. And he said, it was the greatest lecture. And I said, it was a great lecture. That's right. He said, no, it was literally the greatest lecture I've ever been to. And so it left a mark on him. And why was it so great? I think, you knew what your message was. That was the starting point, and it was based on, a lot of great papers. But then the way you delivered it, it was funny, it was engaging, it was entertaining, it drew in the audience, it had all those sort of features of a terrific lecture. And ever since then, I've always tried to do better in my own lecturing, having seen a great lecture. But when you do it on Zoom, it's not the same, Dr. Welch.
No. And of course, I think it's important to have fun.
Yes.
I think that's an important part of communicating, particularly in person, to connect with an audience. And I've always felt that way about teaching. If you're not having fun, if you're not interested in what you're talking about, why the hell would the students ever be interested? So you got to be genuinely interested in what you talk about. And I think it's good to have fun. Boy, it's hard to do that on Zoom. I mean, we're going to have some fun here this afternoon.
We will try to. Yeah. But you're absolutely right. It's very hard to have that.
Have fun on Zoom.
Have fun on Zoom.
Really?
It's like what Zoom's
we'll
not
do
meant
our
for.
best, though.
So let's talk about, there's so many things you've been working on the last couple of years. Why don't we start with your New England Journal Melanoma paper? And so I thought this was really interesting. And, this is sort of based on a lot of the work you've been doing, which is looking at the SEER database, and you follow trends in incidence and death. And one of the very interesting things when you look at melanoma, the incidence of making a diagnosis of melanoma, that's on a roller coaster, up. Yeah,
sixfold since 1975.
But death per 100,000 age adjusted is as flat as it comes. So two possibilities.
About perfect. Yeah.
Perfectly flat. Two possibilities where every year we diagnose more cancer and we get proportionately good at treating, keeping that death, just the right amount of improvements in treatment.
Yeah. Not too much, or mortality would fall, as it has, by the way, just to get out the last few years. And that's great.
Yeah.
That has nothing to do with early detection. That has to do with better treatment. And you know a lot more about those checkpoint inhibitors than I do. But mortality has gone down the last few years. And that's an advancement in treatment. That's great. But for 40 years, we've had basically stable mortality. It's up a little bit in older men, totally flat in women. But we've had this incredible surge, sixfold in melanoma incidence.
And that's remarkable.
It's remarkable.
Yeah. And I guess your piece brought together a bunch of divergent data to make the argument that the only thing that explains a sixfold increase in finding a cancer with absolutely flat mortality until the advent of checkpoint inhibitors, the only thing that explains that is you're finding things that had you never found, they never would have gone to lymph nodes, they never would have spread to the lung, and they never would have killed you. Yeah. If you had just left them alone, you'd have lived your whole life and you never would have known.
You're beginning to identify a whole new population of tumors, the biology of which you know nothing about, except we now have good evidence it's not killing people.
It's really an important finding. And talk a little bit about what the pathologist sees under the microscope, because you had a really interesting I think, subpart of your essay where you talked about the pathologist and how the pathologist may be contributing to this problem as well.
Absolutely. And to be fair, we may be asking pathologists to do an impossible task, right? We've always, if I can just step back, when we originally were sending them tumors that we could hold in our hands, the size of baseballs that surgeons were removing at autopsy, there wasn't a lot of debate about what it was. The clinical setting was such, this is aggressive cancer, it's large, it's spread, so forth. And their, histopathology, only confirmed what physicians
we already knew.
Sort of knew at the bedside. But as we start sending them smaller and smaller lesions, that we've discovered, a number of problems arise. That they may still look like they have some abnormality in cellular architecture or in the individual cells, and so forth, but that may not have any bearing on the actual dynamics of the process of what will happen in the future. And so the pathologic gold standard, questions are they're legitimate questions about what it means. Of course, they're all very concerned about, quote, missing a cancer. So if anything, their standards are falling over time. And we give a little example of that.
Right.
And I think the reality is that they can't tell us what clinicians want to know. Is this a cancer that's going to matter to someone? And so we may be asking them to do something that they just can't do. And that's just added a whole new layer of uncertainty as we start finding things in really early stages. And that's happening across cancers. And of course, the other thing that happens is it begins to really matter who your pathologist is. And different pathologists will say different things. And that was actually very well demonstrated in melanoma with the NIH Consensus Conference in the 80s, where they sent out a bunch of different, a bunch of slides to different pathologists and got a bunch of different answers.
That's fascinating.
Yeah.
I think what you're talking about is something that's happened in so many places in medicine, which is 50 years ago, the entity we cared about was a clinical entity. The patient has died of metastatic melanoma, and then the doctor's looking and he's like, this is what it looks like when they die. Or a patient had pulmonary embolism. Why? Because they had bulging neck veins and they had shortness of breath and crushing chest pain. Yeah. And that's what a PE means, and it's highly lethal. But now we get a scanner that can find a PE so small, smaller than your fingertip in the distant part of the lung. And we treat it the same way as we treated that person, and now we find a melanoma so small, it's like a mole on your hand. And they look at the margin and they find it's melanoma, it's invading, and we treat it the same, and we think it's the same thing. And then the last thing I'll tell you is they've done blind biopsies of the esophagus in healthy people, and they find a lot of the mutations you find in esophageal cancer.
Right.
So, the visual appearance of a tumor on histopathology, the genomic information in a tumor, we have always assumed that this is the demarcation between healthy and disease.
And will tell us the natural history.
Yeah, and will tell us the natural history. But we just don't know. We've never really sampled the denominator.
Right. And this is a general problem, I'd say, that sort of happened over the course of my career of, So I've been interested in the problem of diagnosis. I'm a health services researcher, for lack of a better term. And most health services researchers focus on the question of treatment. And that's, of course, really important. Who gets treatment? Does the treatment work? And so forth. But the only way you get to treatment is through diagnosis. So I've been sort of interested in that upstream step of diagnosis. And of course, in the past, diagnosis was made in someone that came to you. And they came to you because something was wrong, something was bothering. And what makes screening so different and incidental detection is here you're dealing with asymptomatic people. And that's a whole different group of people. And you're looking hard to see if there's something wrong with them. Well, you may find the same things you do in the symptomatic person, but it means something totally different.
Right.
You already have some additional piece of information. And I think that subtlety, and that goes right through to your pulmonary embolism example, to a cancer example, that subtlety is often ignored. And so one of my general comments to physicians is, don't forget about symptoms. They really contribute important information.
I think that's a brilliant point. And
I don't know if it's brilliant. It's an obvious point at some level.
It's obvious to some people, but not to others.
Particularly when you're talking to medical students, you have to wait, how's the patient feel?
It also matters. Pathology matters based on how you found it. So we know a lot about prostate cancer cores when taken in a blind biopsy. Mm-hmm. Now people do an MRI and they point the needle at the thing they want to hit. And so now they're saying, oh, we'll use the same interpretation. If you find a core full of 7 or a core full of 8, it'll mean this. But it's different. Now you're pointing at what you want to hit. And so what you're doing is you're taking a lot of people who hitherto were 7s, you're making them 8s, or hitherto were 6s, you're upstaging people. You don't see what you're doing because you're aiming. You didn't aim before. Right. I got to ask you about COVID-19 then, because it's a diagnostic question as well. Obviously early in the pandemic, it was clear people came in very sick and then they were diagnosed. And if anything, they weren't adequately diagnosed. But now it's an interesting situation because everyone has home tests and they have varying sensitivities and specificities, and schools and daycares. Everyone's very worried. And so you have screening and testing like you've never had before. Asymptomatic kids pooling saliva, one test positive, we're going to close the school. You can have, and I guess I wonder how you think about this. It's hard to keep your finger on where things are because it keeps changing.
Right. Absolutely. And Vinay, you're taking me outside of my lane.
Okay.
So I'm not thinking a lot about COVID testing, but it certainly brings up a whole bunch of issues for sure. I think the one thing, occasionally I've been asked, what does this say? What does cancer screening tell you about COVID testing and so forth? And my sense is, wow, these are really different things. In one hand, you're talking about an infectious disease, and the other hand, you're talking about a chronic disease. And I think the one thing I always need to remind people is my risk of getting cancer doesn't influence your risk of getting cancer.
I think that's true.
And when you're an infectious disease, you're in a kind of a different world and a different set of conditions. And I want to be honest, I haven't taken the time to think about it the way I've taken the time to think about cancer screening.
Well, I look forward to maybe when this is all over, you do, because I'd be very curious. I think I absolutely agree with you. It has that dimension that this doesn't have. That externality. But I do think that the things it has similar are, you
look harder, you find more.
You look harder, you find more. And we don't, and we've never.
And the typical case is less sick.
Yes. And we never looked this hard in 1990. Imagine we looked this hard for whatever the strain of flu was in 1990. Who knows what we would have found?
God. If you imagine we were testing for flu every winter.
Every winter, yeah.
And so every week.
Let's come back to your wheelhouse, liquid biopsy.
Okay, we'll come back to melanoma. Yeah.
Or you want to do melanoma a little more? Yeah.
Well, I do want to do one, and I don't know if you.
I haven't watched the video by Robert.
Do you post any links?
I'll post links. I'll post.
Because I do want to say that just 2 or 3 days ago, I was sent a video of a talk given by Robert Swerlick, a dermatologist now at Emory, and may have been at Emory at that time, at the Mayo Clinic in 1995, April 21st, 1995. The only reason I can remember the date is it's my 40th birthday, which was kind of interesting to be sent a talk given on my 40th birthday. Everybody in your audience should now write down that date so they
send you presents.
No, don't send presents, just send money. But sorry. But it was a great talk. And it of course, it was a rude reminder that I've never had an original idea in my life. He went through the incidence in mortality. He went through all the increase in incidence was early stage, thin melanoma. He went through the Livermore story. Do you know the Livermore story?
No, tell me.
Do you know where Lawrence Livermore Labs are?
Yes. Not too far from here.
Right across the bay. Right. Well, so in the 1970s, and you know what they do? Like they got
high energy physics and stuff. Yeah,
Department of Energy. It's like all sorts of scary stuff. Well, they had a big melanoma epidemic in the 70s. And everybody was worried, like, oh my God, the lab, something's going wrong, and the lab gets involved and starts having melanoma screening of their employees, and the epidemic gets worse. And then someone realizes, wait a minute, we have another lab just like Livermore. It's in New Mexico. It's Los Alamos.
Right.
But same there's none of that there.
Right.
There's none of that. Well, wait a second. What's going on? We got this epidemic in Livermore. We don't have. And then they realize it's all early stage disease. They have 3-4-fold rates relative to other people in the area. It happens in family members of employees, but it doesn't seem to matter how long the employees have worked there. It doesn't seem to have any relationship to their exposure to the lab. And then they realize it's really an epidemic of diagnosis. That what probably happened, that 1 or 2 patients really did develop and were found to have a bad melanoma. Everybody got nervous. And in fact, the lab itself got involved in promoting early detection campaigns and screening people. And all of a sudden, you had a melanoma outbreak that actually lasts into the next generation because these people are so nervous about it. They're getting more surveillance.
That's fascinating. I mean, and it's also, it's similar to...
And he told that story in 1995, and I included it in my book in 2000. It's a sort of a powerful example of how physicians, or how the system can create an epidemic.
And it's similar to comparisons of, like, wasn't there a classic comparison of Seattle to New Haven in prostate cancer? And it was just like same types of people, but the incidence was massively increased in the East Coast.
Seattle.
It was just Seattle, right? Seattle was the ones that loved to screen, right? Yes. Yeah. Very similar. Talk a little bit about, I mean, obviously there's always pushback when you publish these articles. And I think the reason there's a pushback is that the person doing it doesn't see what you're seeing. They see that the doctor who goes in the doctor who decided to be a doctor and melanoma doctor is not a bad person. They're a good person. They're a smart person. They wanted to help people. And then they've definitely seen the horrors of melanoma. They've seen a few people die.
Absolutely. They've seen the worst.
They've seen the worst. Untimely ages, 30-year-old die, breaks your heart. And then you start to cut this out and you see, you save lives. You cut it out and then it goes away and the person doesn't die. And you saw the person die, and it's so easy, I think, to become seduced by that. And your thoughts on that, the seduction of the individual practitioner?
Oh, absolutely. I mean, the misleading feedback from early detection is unbelievably powerful at every level, at the patient level, at the societal level, and at the physician level. And since you first wanted to talk about the physician, let's just talk about the physician level. It's right that physicians who are expert in the field think about the bad case. They've seen the bad cases, and there's no doubt there are bad cases of cancer. No one questions that. And their natural desire is to not see that, right? And that's good. And so they want to find it early. And they look early, they find it early. And those patients do good. That is just really powerful feedback. And then all of a sudden, at the same time, when they look earlier, they find more cases. And that, at some level, always feels good to us. We find an early case of cancer. We feel good about that.
Right.
And they all do well. And so it becomes very positive, a cycle of wanting to find more of that. And that's really misleading, and it encourages you to find a whole new population of patients, many of whom can't be helped because they were never going to experience the problem, some of whom you may find early, but they're going to go on to late stage disease anyway,
right? Or
some of whom will be every bit as treatable late as they would have later when they produce symptoms than they were then they, will be every bit as treatable as they would be early.
Right. Let's take a hypothetical and walk me through your thinking. Let's say we took everything you know now and we teleport you back, and you're that 40-year-old man in 1995. And let's say your back probably feels better, and
my back is good, man.
Oh, your back is good.
Don't raise a back issue. My back is good.
Well, I had a friend who did spine surgery for many years, and he said, after you do spine surgery for a few years, your back will never hurt again. And so I was like, okay, interesting. You'll never hurt again.
Okay, yeah, I get it.
So yeah, so let's say you're back in 1995. You're 40. You have an unlimited budget, and you know what you know now. And let's say you actually get all the dermatologists to consent, and you're going to run a randomized controlled trial of the annual checkup, the skin check,
skin exam.
Yeah. So I wonder if you might just talk about because this will actually apply to the liquid biopsy question. How would the study look like? I suspect one arm's going to find 6 times as much disease as the other arm, right? That's going to
at least, probably more.
Yeah, probably. And then what's your primary endpoint of the study? How long you're going to follow? Yeah,
your
so let's talk it through. Yeah,
endpoint in a trial of melanoma screening will be melanoma mortality, and I fully expect actually you'd see no difference.
Okay,
but that would be the trial design, and it would have to be pretty big because melanoma, although it definitely is a cause of cancer death, it's down there on the list. And so it would have to be a really big trial. I have no question about the effect on incidence. It would be dramatic, at least 6-fold. It might be 10-fold.
So you might have to do, million people getting yearly skin checks one arm versus million people seeing the doctor, their just routine exam, listen to the heart and lungs, but no skin check. You might expect that the arm that gets skin checks will have 10-fold the amount of melanoma diagnoses. They'll have hundreds more, thousands more.
Their 5-year survival will be 100%.
Yeah. Okay.
By the way.
Among
and
those,
another really misleading.
Yeah. So talk about that. So
what? 5 years survival, because you've diagnosed so many extra cases, you inflated both the numerator and the denominator of the survival statistics with patients that were never going to die of their disease. So 5-year survival will go through the roof. So
one arm will have 10 melanoma patients and 5-year survival will be 60%. The other arm will have 10,000 melanoma patients and 5-year survival will be 99.9% or something like that.
Yeah, that's a little bit exaggerated, but you got the general drift. Yeah. Yes.
And I guess, I think it's a useful thought exercise in a few ways. One, as you start to think about
and if I just one other thing, forget just the number of melanoma cases. Imagine the number of biopsies. The number of biopsies will be 1,000-fold higher. Yeah.
And the number of Mohs surgeries. And of the biopsies, some fraction will get sentinel node biopsies and get node dissections, and particularly in those years. And some people will get lymphedema of the hand because you did cut out all the nodes in the arm, or lymphedema in the foot because you cut out all the nodes in the leg. So some people may even be harmed.
And some will have difficulty getting health insurance.
Some pre-existing condition.
Yeah, and life insurance and so
Would it be? As I imagine this experiment, would it be fair to say that not only you believe it wouldn't reduce mortality, but you also believe the arm that does it will have a net health decrement? They'll be worse off for doing it.
I'm afraid that's probably what I believe. Yeah. I might be wrong, but I think that the net effect will be harm.
Yeah.
I remember, you remember there was a flurry of interest in total body CT.
Of course.
Screening, right? That was in the early 2000s, and I actually got close to trying to pitch a trial to the VA of total body CT, and then I realized you're really supposed to have equanimity about the outcome, and I didn't have any equanimity. I thought, oh my God, this would lead to a whole lot more surgery, and people would be hurt.
Yeah.
And the melanoma one, it's luckily the intervention for the cancer is relatively minor compared to prostate, breast, and lung. So I don't want to overstate the harm, but I think the net effect just makes people more worried, and it costs money, and and increasingly this is coming out of patients' pockets. It adds a lot of hassle factors going back and forth and making appointments, and you're in surveillance loops, and you're worried about the next mole. And yet I want to come back to, we're getting better at treating the advanced disease.
Right.
And the better we get at treating the clinically evident disease, the less important a case you can even make for early detection.
Yeah, I guess I agree with everything you said. And I also come back to, I sometimes wonder what it will look like 100 years from now, 1,000 years from now, when people look back on this time. And I think they'll look back on it with sort of a shocked fit, like, how we look back on people came before us and like, how could they ever not have known? And they'll look back on it and say, it's an operation that utilized $100 billion, tens of billions of dollars globally.
Right.
It employed hundreds of people, thousands of people.
Right.
It was prestigious work. It was thought to help. And if anything, it just swallowed societal resources and made people worse off. How could they have done it?
Right.
Let's turn to liquid biopsy, because I think this is so interesting. So, just to give leaders a little bit of primer, a number of companies, particularly this one company, GRAIL, they're pursuing a liquid biopsy. And basically, they draw your blood and they look for proteins and genes that they think are abnormal in cancer. And in some fraction, it flags and it says, you got a problem here. You might have a cancer. Then there's another part that I always struggle with. It's that, telling someone they might have a cancer in their body, it's not terrific if you can't tell them where it's at. So you got to pinpoint it. So once you think you find something, you got to scan them. And then sometimes it might not show up on the scan. So you got to scan them again, scan them again, scan them again. And then you might eventually see something that looks like you're going to pursue it. You got to cut it out or biopsy it. It might not be the thing that's secreting the thing you're catching in the blood.
Right.
So I wonder if you might talk through GRAIL and I guess how you think about this and where we are with it. And UK is, of course, ahead of us. Yeah.
Yeah. So first, the term liquid biopsy is a pretty broad term. So let's specify it a little bit. I think of it as specifically going for so-called tumor DNA, cell-free tumor DNA. And of course, we all have DNA in our blood. And the question is, what portion of that, separating the normal from the abnormal, and what does that mean? And to be fair, some of the tests are actually throwing in, along with the cell-free DNA, oldies but goodies, like CEA and alpha fetoprotein and CA19. It's like, are you kidding me? Things we've already sort of said. This really, but it's an incredible battery of tests. Think of it as a SMAC 20 on steroids. Looking for things to be wrong. So obviously that always makes me a little nervous from the get-go. That said, let's be clear that the screening setting is one application of it. The very reasonable kind of application is for people with established cancer. It's a diagnostic test. It's a way to get some sense of tumor activity, maybe some way to guide therapy. And it is FDA approved in a number of settings. And I think it's entirely possible this becomes quite a useful way, to gauge the response to therapy and to maybe select treatment as different clones arise and so forth, in a relatively non-invasive way. So I want to, I think sometimes I get tagged as, some Luddite from Vermont that, you can't even turn on a Zoom cam. Well, I can do that, and technology has some real use. And this may be very useful in patients with bad cancers. So I want to be clear of that. But the money's in screening, right? Everybody wants to produce screening tests because the markets are huge. Because that's, GRAIL would like to sell their test to Medicare bennies, to be used every year. That's a big market. That's a huge market. And that is a bunch of people where it's hard to make well people better, right? But it isn't hard to make them get more involved in medical care and have a lot more downstream events. So that's that's what I worry about whenever a screening test like this comes up.
And the first thing I always see these, and I think that's absolutely right. I mean, the first thing these companies do is they always take some set of 25% healthy people, 75% known cancer, and then they apply.
Usually, it's advanced people with really bad cancer. Correct. And medical students.
And that's important to say. It's important to say. You're right. It's 25% the healthiest of the healthy medical students, and 75% people with rip-roaring metastatic cancer. The TNF alpha is pumping in their veins. Right. They're getting Trousseau phenomenon thrombosis.
And we distinguish between these two. Yes, we can.
Yeah. Yeah. And so I was always taught. But the more I think about it, I don't know. I mean, I was always taught sensitivity and specificity are characteristics of tests, and a post-test probability is a characteristic of test plus population. And I was always taught that you could validate sensitivity and specificity in these extremely skewed cohorts and apply it to regular people. But the more I think about it, I feel like, it's not always true because...
I'm really glad you brought this up, Vinay. And I think you and I probably have done the same lecture many times, the 2x2 table, right? And we get everybody into the 2x2 table. And I think there's a lot of utility in not so much the calculation of posterior probabilities, because no one knows the pre-test exactly, but learning some of the qualitative insights is really important. And so the 2x2 table is a useful way to start with medical students. But let's be clear. The idea there are only two columns is a joke, right? There are people who are well and there are people who are sick. Well, there's a lot in between, and it's the in between that makes it really complicated. And in some ways, I think our binary view of the world has left us, is an oversimplified one, and have left us not really, to be distracted by things. And one is we always want to be sensitive. So we want to catch all the disease. Well, of course, whenever you do that, the basic lesson from the 2x2 table is you lose some specificity and you start telling other. But it doesn't tell you anything about overdiagnosis, because that's not in the 2x2 table. Because we have these columns, either you have disease or you don't.
And be clear, false positive is not overdiagnosis.
Yeah, these are totally different things. Let's just remember, a false positive person is told they don't have cancer, the test was wrong. Right. Or sometimes people are told something's wrong with you, you're at high risk because of this, but
that's a way of sugarcoating the false positive.
But overdiagnosis is totally different. You're told you have cancer, and now you're being treated for cancer. And that gives you credit on the sensitivity side. Well, that's not, so we're always thought, oh, geez, of course we want to maximize sensitivity. No, I don't want to maximize sensitivity. And coming back to liquid biopsies for a second, and I think this is interesting. The early work with GRAIL shows that it's actually not very sensitive to
early stage tumors,
early stage breast and prostate cancer. Well, I say that's a good thing, right? It isn't fine. And by the way, that sort of passes the lab test. Early stage breast and prostate.
It's not secreting a lot of stuff systemically.
It's not putting a lot of cell. Okay, the world makes sense. That's a good thing. And in fact, even some of the GRAIL authors have touted that one thing this test might offer is less overdiagnosis of these two cancers, which I think would be a good thing. Except, of course, as GRAIL suggests and other liquid biopsy companies suggest, they're going to suggest that you continue all your conventional screening. So,
but your point is really terrific, which is that, I mean, obviously that this binary world is wrong. That's a terrific point. Also that, you've popularized as much
as I want to keep score. How many terrific points do I have?
Many, 5, 6.
I'm just scoring it for myself.
We got to have fun these days of Zoom. There's nothing else to help us. Okay. So, you popularized the idea of turtles, rabbits, and birds. And birds are the cancers you find, but they've already metastasized. So finding them probably is going to subject you to local treatments, but maybe you don't avert your final fate. Turtles are, of course, they're never going to leave the barnyard. They're just going to stay there. And that's partly what they're finding with melanoma. Rabbits are what you want. Rabbits are the ones that we're going to spread, but you're interdicting on them before they spread. And what the test should be looking for is sensitivity for rabbits, not sensitivity for turtles or birds, but we don't know which are rabbits or rabbits. Right. And so we're forever doomed that, we're ever doomed. You want to talk about that a little bit? Yeah.
Well, the world's a complex place, and just to finish the 2x2 table, that sort of denies that complexity.
Yeah.
And you're right. What we'd like to do in terms of early detection is find those cancers that are ultimately going to matter at some point where, and this is important, it's not just enough to find bad cancers early. First, in addition, early treatment has to confer some benefit over later treatment, or else you haven't gained anything. All you've done is started therapy earlier and put people into therapy early, which arguably, if they don't live longer, is a harm, right? Because they're otherwise asymptomatic and they're experiencing now cancer therapy, which you can speak to better than I, but it's hard on people. Still fair comment?
Still fair comment. Yeah.
So that's the challenge. It's not just finding bad cancers earlier. You got to find bad cancers earlier, and earlier treatment has to confer an advantage over later treatment. And that can't be measured in terms of survival, because that's biased right off the get-go, because you started the clock earlier. It's got to be measured in terms of mortality.
Let's talk about your really elegant paper in the Journal of Medical Screening, which was on all-cause mortality as a primary endpoint for a GRAIL multi-cancer screening trial. And basically what you and your colleagues talk about is they are currently running sort of a very simple 70,000 randomized trial in the United Kingdom of this blood-based cancer screening test, GRAIL, which has, I think, a valuation of a few $1 billion. It's already highly valued.
That's outside of my wheelhouse. Okay. I don't know their valuation, and I'm not a shareholder. So,
okay, good. Me neither. But in this paper, you talk about, we know cancer is a substantive cause of death. We're always dueling with the cardiology people. We might lose more disability-adjusted life years because it takes people in their midlife. But ultimately, cardiovascular disease and death is the number one cause of death. But so since cancer is
very close now. Getting very close.
You go by Lawrence Livermore Labs, it's neck and neck. It depends on the pollute. Okay.
No. I'm talking now mortality.
Mortality, yes. For yeah. And that's because we're getting better at treating cardiovascular disease, so people die of something else.
That's right. And it's because there's less smoking, which of course drops both.
Yes.
To be
drops both. Yeah.
Yeah.
Drops one faster than the other. Drops cardiovascular disease faster than when you quit.
Exactly.
Right. Yeah. So in this paper, you talk about they have enough people doing this that you could actually just see, do they live longer from doing this?
Yeah.
I want to talk you through this.
I think this is really important. As you know, but maybe your audience doesn't, I've long argued that, what patients really care about, what they hear when they hear the word saves lives is the risk of death will fall. The only way to really show that is change the death rate, the all-cause death rate. And that does take really big trials when you're dealing with a very rare cause of death. But once you start advertising that you're screening for 50 cancers, you're essentially screening for all. And cancer mortality is about 1/3 of all-cause mortality. That you ought to be able to see.
Yeah. And I think that's
important.
important.
And one of the things I've been really worried about all along is that one of the things that happens with screening is that you may artifactually be able to lower one cause but then inadvertently raise another cause, the so-called off-target deaths, or that there's something about getting cancer, this is so-called aging soma process, that is a reflection of the host, that the host is now less healthy in general and is more at risk for all sorts of kinds of death. That the soma is aging and is at risk for any number of causes of death. And so the trial that I always come back to, because I was just so struck by it, was a trial that really got us to screen for colon cancer, which was the Minnesota colon cancer project in the 80s, which randomized people to FOBT testing versus not, and had a pretty powerful result, a 1/3 reduction in colorectal cancer mortality at 15 years. And it was, really the reason colon cancer screening really starts in this country. And, about 10 years ago, they did a 30-year follow-up. And again, you still had 30 years after the trial, you had a 33% reduction in colon cancer mortality. The cumulative risk of dying from colon cancer in the control group was 3%. And in the intervention group, it was 2%. That's your 33% reduction from 3 to 2%. But it was real. There's no question it was real. But in the same article, the figure 2, they showed the all-cause mortality curves, and you could not distinguish the two. They're just right on top of each other. At 30 years, 71% of the patients were dead in both groups.
And I think sometimes, people say, well, you got to die eventually. But you're making a different point. It's not the final death count. It's along the way, at every moment in time, the Kaplan-Meier curves are indistinguishable, meaning that you're not saving a colon cancer death dying of heart disease 10 years later, or the curves would split.
Right.
Right. So it is that there is something going on. It's not budging the all-cause mortality.
It's not budging the all-cause mortality. And so whether it's aging soma or off-target deaths that you're missing, to me, it's an important question, particularly if we're going to sell these things as saving lives.
Right.
And by the way, I think medicine can save lives. I want to be real clear about that. We do good things for people who are acutely ill or injured.
If you had a STEMI right now, stenting you open, giving you Plavix, aspirin, maybe 15 percentage point increase in mortality in 20 days. Massive. Huge. So doctors do good things. Yes.
But when we get involved with the it becomes a whole lot less clear. So my argument with liquid biopsy, because this is a big, GRAIL's suggesting $949 a test every year. That's a lot of money, right? Yeah. For every Medicare beneficiary.
Yeah.
That's real money. Yeah. And by the way, make sure we talk about Congress before we leave
let's talk about that.
Because there's a bill here. But my argument is pretty simple. That's a big deal. And by the way, that's just for the test. It doesn't say anything about downstream testing and what happens when we do this. I think this is a time we ought to know. You've randomized 140,000 people. 70,000 are going to get the test annually. 70,000 are not. Primary outcome, it ought to be all-cause mortality.
Right. I think that is easy. Before we talk about the Congress and the bill, I want to ask you a tough question, which is, what is cancer?
Yeah. God, you're asking, an oncologist is asking a general internist. I'd like the audience to think about that for a second. I don't know. I'm the primary care doc. I'm going to ask an oncologist. What would you say?
Okay, so I guess what I would say is cancer is a condition that results in, I think the first thing to put in there is what people think, which is that something bad will happen to me. So it makes you feel bad or kills you. That's number one. It's a condition that makes you feel bad or kills you. Number two, often characterized by growth
cellular disarray.
Yeah. Growth of slightly abnormal cells. And I think the other thing we forget is like the cancer and ourselves, we're so close. We look like you and your twin brother, you know? And that's also why killing it is so hard, because it's so close to us. It's not like infectious disease. It's okay. Right. So, and then 3, in the setting of, I think we forget, there's all these things we don't know. In the setting of immune dysregulation, maybe my immunity is not good, or my body is old or frail or vulnerable. Right. And it's all those things. And by that definition, I think papillary thyroid cancer, it's not cancer. I mean, it histopathologically is cancer, but it's not going to cause you harm, you know, and all these things. So I wonder how,
I think the patient definition is, of course, the one I care most about. And what most patients hear and what the dictionary says is, you know, it's an uncontrolled tumor, the natural course of which is to lead to death. I mean, I think that's what most people have in their mind. That's right. At least one dictionary definition. And of course, we're changing that definition all the time in practice, but that is certainly what people hear, and you know, is the disease we want to deal with.
Yeah, and I think, I don't know, I see these articles called the Hallmarks of Cancer, you know, the classic, and it's all about like what are all the molecular things that go wrong in cancer. Right. But I think one of the problems is they don't even start with the definition, like what should actually be in this bucket and not. Right. And what cancer means to us is, you know, anything the pathologist tells you is cancer, right, whether or not the person lives a long and happy life or is dead next week. You know, that's all, you know, and that's, and it's changing every year because they're constantly changing the rules. Right. And that's not a great definition. So let's talk about the Medicare. You know, this concerns me, I think, a lot, and you've written about it with Barry Kramer, that in the proper world, you would generate evidence. The evidence would persuade doctors, and the doctors and patients would seek reimbursement for that based on evidence. In a crazy world, you generate hype, and then you get the politicians to grant your funding, and then you never generate evidence, and then you bamboozle doctors later. And that's the world we're living in. So what's going on with this test?
Yeah, well, I'm not sure that would have been my one summary, but it's pretty adequate. So just so your listeners know, there is a bill now in both the House and the Senate called, I believe it's the Medicare Early Detection Act, multiple cancer early detection acts. Do you have it right there in front of you?
Yeah, I'll pull it up. The Medicare Multi-Cancer Early Detection Screening Coverage Act of 2021.
Okay,
a bipartisan.
So I didn't quite get it. Yeah, and by the way, I hope you put a link to that.
Yes.
Bill so people can read, or a link to my piece, which has a link to the bill.
Sure.
It's bipartisan, and you've got it right in front of you. So you tell me, what is it? It's about 100 plus House members and
144 House of Reps and 30 co-sponsors in the Senate. Yes.
Right. And I just want to say from the start, you know, when I hear bipartisan, I feel good all over. Like, I mean, that's great. And then it has to be, what do they agree about is about another screening test. It's like, oh, come on. But what it's doing is it's really saying that Medicare should cover these tests. Now, it's unbelievable to me that they would do this first for us, you know, just getting involved in any particular aspect of medical practice and saying Medicare should cover it. Right off the bat, that has me a little bit. Should the legislature really be making decisions about individual tests or individual treatments or any, you know, but anyway, that it really mandates coverage, quote, pending FDA approval, which makes you wonder, why would you mandate coverage pending FDA approval? Are you trying to influence FDA approval? I mean, why would you tie up the Senate, you know, before FDA's approved something? You'd never do that for a drug.
Right.
It's, you know, it just looks like Congress is being heavily lobbied, and, you know, these companies are trying to make sure they can garnish Medicare resources before, not only has it ever been approved, but before we really know whether it works. part of me wonders whether this is a way to bypass the U.S. Preventative Health Services Task Force and having a real review of this thing. Of course, there's nothing to review right now. It would be an eye for sure, insufficient evidence. But to me, that's very concerning. It just speaks to the very strong financial interest in making this a screening test, is making this whole, and there are a number of companies. This is not just GRAIL. This is multiple companies.
Yeah. They're all pursuing
who would love to have sort of blanket coverage of multi-cancer screening.
One thing they always say that irritates me is that they make the argument, which is true, there are severe racial and socioeconomic disparities in outcomes by cancer. Ergo, you should use our test. But what always bothers me is we do not know. Your test may even worsen those outcomes because it may find more overdiagnosed cancers in racial and socioeconomically disadvantaged people.
I think the real problem is this is a huge distraction. If you really care about health disparities, first, stop worrying about Medicare beneficiaries and start worrying about people with long life expectancies, the young, children, young adults.
Correct.
That's the first thing. And stop thinking about medical care and start thinking about more basic social determinants of health. Think about housing, jobs. It's so
School.
Basic.
Yeah.
And schools.
Nutrition.
Exactly.
Yeah, right.
Don't think you're gonna biopsy your way out of health disparities. That's crazy, Bill. Really.
I find it the most disingenuous.
Yeah, it's really that just gets me going. It's just crazy to, if people who really care about health disparities should be focused on young people, and they should be focused on the poor, and they shouldn't be thinking about healthcare as the way to get out of it.
I think that's well said. I want to give you the closing thoughts, but I think these have been, throughout the pandemic, you've kept yourself busy, focused on these important issues in cancer screening. I worry a little bit about GRAIL. I worry that they are going to sneak up on us. Yeah. I meant to ask you, the USPSTF task force.
Are we going to get to talk about Taiwan?
Okay, let's talk about Taiwan. Yes. Okay, but last question, USPSTF, and then we'll do Taiwan, and then we'll wrap up. Okay. So the USPSTF, the one thing I noticed is they changed the colon cancer screening to 45, and from 45 to 50, they have had no randomized data. They have a model.
Right.
And I am a little nervous about this change. I wonder if you might talk about it.
Well, this is a perfect segue, and I'm a little bit nervous about them expanding lung cancer screening to a broader group.
Let's talk about that.
Smoke. So, they're certainly under pressures.
Yes.
Where disease is that they ought to be screening for. So I have an analogous. I know about the colon cancer expansion, and there's also been an expansion in lung cancer screening, and I think they are both concerning. So
let's talk about the lung cancer screening. Trials in smokers extrapolated to
the general population, and this is really happening throughout East Asia. But we have an article taking place in Taiwan, where it's really remarkable that they're really being the promotional material features women, and features actually quite young women, and I'm very pleased that JAMA Internal Medicine was willing to print some of those they're really not advertisements, they're sort of news stories. And they feature young women going into scanners for lung cancer screening. One thing to know about Taiwanese women, not like American women, is they've really never smoked. Less than 5% smoking prevalence since 1980. So this has been going on for about 15 years now, and early stage lung cancer is skyrocketing in Taiwanese women. It's also up sixfold. No change in late stage disease in Taiwanese women, and no change in mortality. That looks like straight on screening effect, and it looks virtually all overdiagnosis, that you're finding a whole new group of biologically indolent lesions in non-smoking females. They're operated on. They're largely getting video-assisted thoracotomies. And it is, you know, I think the first example of sort of population-based overdiagnosis of lung cancer.
Right.
Now, by the way, it's been seen in the trials.
Right.
And in fact, the trials worked very, very hard to limit the problem of overdiagnosis. They
by
knew
being
it was
selective.
a problem. The pulmonologists have always been sensitive to this problem. And they specifically had growth protocols.
Right.
So they'd say, you know, if we saw a small lesion that might be worrisome for cancer, what we're going to do is we're going to repeat a scan in 3 or 6 months and see if it grows. I think that was a huge advance. That was a huge advance because now you're getting some information that the pathologist can't tell you, the molecular people can't tell you. It's just bread and butter. Time, the diagnostic value of time. Is this thing growing? Really important information. But that may not happen in the Wild West of actual medical care. And it certainly didn't happen in Taiwan. That's why there are all these extra cases being found. They're being operated on. And to me, the unbelievable finality of this story is that Taiwanese women now have the highest lung cancer survival rate in the world.
Of course, because they found so much.
Because they found, and there the whole story's there. All that misleading feedback. You come back with this incredible 5-year survival rate. You have survivors who believe their life has been saved. They become very strong proponents of the test, and that's what we're up against. It's that misleading. In the financial world is one issue. But the misleading feedback is I'd say even a bigger problem.
You know, I'm still like on the first bus stop on this lung cancer thing because here's where I got off the bus. You know, in the original NLST trial, you know, they have a reduction in lung cancer specific death, and they said they had an overall mortality reduction. But a few years later, Paul Pinsky reanalyzed the data, and the overall mortality is gone. Yeah. And then they had the Nelson trial, which has a lung cancer specific reduction entirely offset by death from other cancers. So totally null. And then I also think about like the interaction clinically. I have so many people, or I took over somebody's lung cancer practice a few years ago and I ran it for a few years. Like the type of person who's getting subject to this stuff. And it's often people who have heavy packy or smoking histories who have often a different philosophy on life. Like, you know, that veterans philosophy, which is that, you know, if it ain't broke, don't fix it, doc. Right. And, you know, I lived hard and I enjoy life and I enjoy a cigarette and, you know, and they worked hard, and you know, some of these people are old people, and some people have like 200 pack year history. You scan their lungs, you find a million things that we're following. I've seen people, quote unquote, cured of small cell lung cancer, which never happened before, but only because you found something you never would have found before. And then they get the repeat cuts and wedge resection, SBRT, wedge resection, chemo, and then adjuvant chemo a second time. There's no randomized data I'm ever aware of that support 2 cycles of chemo. You know, so we're creating this huge monster. Everyone's involved in it. You know, every university is getting their lung cancer screening clinic, and everyone's getting rich off of it. And so I guess, and now, you know, it's extrapolating it to young, healthy Asian women who suffer from a very unique, that's crazy. But it's really the medicalization of the people who like least wanted to go to the doctor troubles me.
Well, I think you got 2 different issues there. I'll just separate for a second. Let me just say at the outset, as a screening guy thinking about screening, I can't imagine a better set of conditions for screening than lung cancer.
Sure.
Right? I mean, it is by far and away the most common cause of cancer death in this country, more than the next 3 combined. Our treatment of advanced disease is pathetic. Right. Is that still fair?
Yes, I think so. Maybe despite some small changes, but not terrific.
Yeah. And a high-risk group is really easy to identify. It doesn't get any better, right? It doesn't.
And it's easy to see because the cancer is in a backdrop of empty space. You know,
that's right. Yeah. So the conditions are as good as it gets.
Yeah.
And the early X-ray, the chest X-ray trials, they seem to suggest, if anything, it made things worse because too many people went into operating. I think the design of the new trials was much better and really broke some new ground because of the growth protocols. So I want to make sure I compliment the pulmonology community, the people that are running those trials. Let's be honest, what's really happened since then? Well, it's been very slow to uptake. And I think there's a lot of reasons behind that, but one of which is that the patient population for whom is eligible isn't that interested. And maybe that's right, because there is a lot of extra procedures going on and the false positives and so forth. But I want to be clear, it doesn't get any better for screening than that. I can't imagine. In Asia, East Asia, you know, what's happening now is really much more broad-based, has forgotten anything about the level of risk, nothing about growth protocols, and it just shows you how far wrong you can go. And the same thing's happening in China. Some Chinese hospitals are doing it for their staff. They just, you know, they've got the scanners, they're just checking people. And I think it's just really important that we tell people the downsides of screening, because I think all the misleading feedback is such it's easy to get sucked in.
You know, that's really well put. And it's a nice way to break it apart. Yeah, because I do think it. So I'll give you the last thought. The last thought I had for you is, you know, take your suggestions for where to take your many talents to in the future. One I have for you is the handheld ultrasound. These days, everyone's a screener, you know, because so many doctors are walking around with a handheld ultrasound, and I'd love for you to kind of think about that, because I think about.
Let me just check right here.
Yeah, let me just check.
I'm just.
And even.
Oh yeah.
Yeah. Gotcha.
Yeah. Okay, that thing needs to come out.
We call it the South Korea method, and also to, you know, to physical exam. They're looking at heart valves, and they're finding things, and they're ordering echoes, and they're looking at volume status, and they're practicing different medicine. And to my knowledge, they've never once done a study powered for the clinical endpoint. The person feel better as a result of me walking around with this wand. And of course, you know, who doesn't want to be the cool person carrying? It looks cool to have the wand. You know, I get it. Yeah. I see it looks kind of nice. Okay, and and at some point when this is all over, I'm curious. Respiratory virus testing, but okay. So I'll give you the last word. You know, this is really a fascinating collection of stuff. I think furthers our understanding of this slippery concept, which is that what's under the microscope isn't what's going to happen, isn't destiny, and that's an important distinction. What you see,
and the other distinction I'd leave your listeners with is the distinction between people who come to you because something's wrong, and those that you're actively looking for something wrong. That's a really important distinction.
Sometimes somebody presents me a case and they go on and on and on about the case, and I ask the question, how did you even find this cancer? And it's like, and then it's like, oh, well, they were about to get another procedure and it was incidentally found, or the person's been coughing up blood for 2 weeks, and that's very
different.
Very different,
Very different.
Dr. Welch, thank you so much for doing this. Pleasure to talk to you.
Stay warm in San Francisco. Can I just tell the audience that you were complaining about how cold it is?
It is cold.
and I just want the audience to know it's 10 below here in Vermont. So
you're
cool. A weenie. But anyway,
it's been great. It's been great.
It's been great. Thanks so much for having me, and stay well.